Primary care in maxillofacial trauma. The objectives of primary care are rapidly identify life-threatening injuries, understand importance of the sequence, initiate adequate support therapy, efficiently organize. So the golden hour, the means the first hour which the trauma occurs, that is victim's chances of survival greatest if they receive definitive care within the first hour after severe injury. So here you can see a graph which shows the trauma deaths. It has trimodal distribution. That is, first one is the minutes. That is massive injury to brain, stem, aorta. This will cause death within minutes. And hours the golden hour which I discussed previously. And days will be because of the bacterial sepsis or multisystem organ failure. Now is the first peak. First peak is the that is many minutes. That is seconds to minutes of injury. It's a result from apnea to the severe brain or high spinal cord injury or rupture of heart, aorta, and other large blood vessels. Next is the second peak. It hours with minutes to several after following injury. That occur during this period are usually due to subdural and epidural hematomas, pneumothorax, fractures with significant blood loss, etc. And third peak, which occurs are several days to week after injury, most often due to sepsis and multiple organ system dysfunctions. And next is timing of distribution of the curve. The global mortality cases are text usually because of road traffic accident and other causes. Road traffic accidents account for 23%, homicide 11%, suicide 15%. And the sequence of priorities change from preparation to the definitive care. And preparation means the pre-hospital phase. Pre-hospital phase means when the accident occurs. It should be with coordination of EMS with hospital emergency, and it can be divided into time of injury, mechanism of injury, patient history. Then we should say the following contents like airway maintenance, control, external bleeding and shock, immobilization, immediate transport to closest and appropriate facility. Now, first step is preparation. That is the hospital phase. In this phase, we should plan the arrival of the patient. Next is the trauma room with equipment. The trauma room should be fully equipped with the instrument necessary for resuscitation, monitoring, warm solutions. Next, followed by trauma stuff, which contains the emergency specialist and laboratory and radiological personal protection for communicable diseases. Next, followed by triage. Triage is the distribution of patient according to their severity of the injuries. The aim is to prioritize the patient according to the severity of injury, likelihood of survival, urgency of treatment, and availability of necessary care. So this is next is a triage, which includes the red signal, which patient requires immediate treatment. The example suicide attempt, or poisoning, hanging, or self-inflicted trauma. Next followed by yellow color, that is patient is stable at the moment and is not any of immediate danger but will require observation. That is passive suicidal ideation, command hallucinations. Next is a green color. That is patient who will require medical treatment at some point that is not more critical. That is drug refill for antidepressants and anxiety medications like that. Next followed by the black one. That is the patient who are already diseased and so there is no need for any care for these patients. Next followed by the primary survey. Primary survey includes A, B, C, D, E. A means airway maintenance and with spine control, with C spine control. B means breathing. C denotes circulation. D is for disability, and E is for exposure or environmental control. The first one we would like to discuss is with airway maintenance species C-spine control. So we should assess the airway with the help of the following things like change in voice or sore throat, noisy breathing that which includes snoring and snidel, dyspnea and agitation, tachypnea, abnormal breathing pattern, and low oxygen saturation. Next is the airway management. That is maintenance of airway patency. That should be the suction should be clear, jaw thrust and chin lift, and oropharyngeal and nasopharyngeal airway. In airway support, we should give the patient 100% oxygen support, including the bag valve mask. Definitive airway includes the endotracheal intubation, surgical cricothyroidotomy, and tracheostomy. Protection with C-spine. So one should assume the C-spine injury if any one of the following five features are present. That is, first one is unconsciousness, multiple system trauma, blunt injury above clavicle, and pain of neck with neurological deficit. That is unable to active flexion of neck due to pain. Next is C-spine injury can be ruled out. Then initially C chin lift or jaw thrust maneuvers are recommended. Next followed by Philadelphia collar, that is prevent excessive movement of the C-spine. So these are the following figure. In first figure you see that the patient is made to lift the chin. Next the jaw thrust opening of the jaw, and jaw thrust is neck extension. That is if C-spine injury is not can be ruled out. Next is manual inline stabilization of the neck. Now, causes of the death from airway problems can be by failure to recognize the need for an airway, inability to establish an airway, inability to devise an alternative airway plan in setting of repeated failed intubation attempts. Next is failure to recognize an incorrectly placed airway, displacement of previously placed airway, aspiration of gastric contents, rapid sequence intubation. And here we go first equipment with all the ECG or meter, BVM, and suction and ATT. Next followed by C-spine immobilization. Next followed by the pre-oxygenation at 100% O2. Then we should followed by giving a sedative like midazolam zero point 0.1 to 0.3 mg, thiopental 1 to 3 mg, like ketamine 1 to 2 mg, like we should give. Next followed by the succinylcholine choline, that is 1 to 1.5 mg per kg, and followed by atropine zero point 0.02 mg per kg. Next followed by inflate the cuff and intubate the patient. Followed by airway devices. Here you can see Gudel's airway, oropharyngeal airway, indication for intubation, like that. Next, indications for intubations that include upper airway obstruction, poor breathing effort, diseases of greater than 8 or rapidly declining GCS, signs of raised intracranial pressure, significant maxillofacial neck injury, persistent seizures, and trauma with inhalation of burn injuries. And this is a diagram showing the definitive airway, that is airway maintenance with C-spine control. That A is a picture denotes endotracheal intubation, and B is the bulb where there is an cuff inflation tube, and C is the trachea, that is the where the tube should pass into trachea, and D is the esophagus. Surgical airway, that is surgical airway is indicated in following situations like inability to intubate the trachea, edema of glottis, pharynx, fracture larynx, severe oropharyngeal hemorrhage, needle cricothyroidotomy, surgical cricothyroidotomy, and tracheostomy. The first one is cricothyroidotomy. Here you should make needle cricothyroidotomy and surgical cricothyroidotomy are the made. The first one is the needle cricothyroidotomy, meaning the needle is introduced into the trachea and then air is pumped. And surgical catheter, that we can create a opening near the T3 or T4 T3 or T4 skin, and the skin is incised, blunt dissection is made, and tube is introduced. Next is followed by the tracheostomy. Next is immediate need for definitive injury. This is the algorithm of the flowchart showing the immediate need for definitive airway. The first one is the suspect C-spine injury. If you suspect C-spine injury, oxygenate or ventilate the patient. If patient is apnea, introduce oral tracheal intubation with inline C-spine stabilization. Followed, if you are unable to intubate, then go for surgical airway. Next, if you are able to oxygenate the patient, if patient is having severe maxillofacial injury, because of that, if you are unable to intubate, then go for surgical airway. Next is if patient is breathing, then go for oral nasotracheal intubation with inline system stabilization. Then if you are unable to intubate, go for pharmacological urgent, followed by orotracheal intubation. Also, then if you are unable to intubate, they go on for surgical injury. Next is the breathing. The first main should look is here. The first three the first three methods are used to assess the breathing are look, listen, and feel. In the inspection, that is the look, you should look for the any tracheal division is present, accessory muscle use, that is retractors, absence of breathing, and paradoxical chest wall movements. That is, yeah, the one chest is moving upwards and there is no coordination between the chest movements. Next is followed with auscultation. Look for any gas exchange. That is, listen with the help of a stethoscope. That is, there should be equal bilaterally, or diminished or absent based on should not be present. Next is followed by palpate. That is, feel deviation trachea, any broken ribs are present, or any injury to chest wall. Then assess jugular ventral pressure, SpO2, air entry into the lungs, and respiratory rate. These are the severe life-threatening complications which can occur when patient underwent severe accidents. That is, first one is tension pneumothorax, massive pneumothorax, open pneumothorax, flail chest, and cardiac tamponade. The first one is the tension pneumothorax. That is, here for this we should assess in near the region of second intercostal space and mid clavicular line. Then next followed with ICD, that is fifth intercostal space and the mid axillary line, that is a newer one. To relieve the tension pneumothorax, you should use the temporary needle of a gauge 14 to 16, and which here the in before we should the space is the where we should introduce needle is the second intercostal space, that is a mid clavicular line. The newer version is the in the fifth intercostal space in the mid axillary region. And next is followed by the massive thorax. Here ICD can be done or rapid bolus of IV with finger lactate solution can be given. Blood transfusion, consider thoracotomy if loss is greater than 1500 ml or 250 ml per hour after initial evacuation. Next is the flail chest. That is a pump contusion. That is, you can use the analgesic drugs. If any respiratory discomfort is present, endotracheal intubation should be done, and this can occur because of the pulmonary contusion. So, pulmonary contusion can be treated. Next, followed by the cardiac tamponade. Cardiac tamponade can be assessed with the help of Bextrade. In Bextrade, you can see distended neck veins, hypotension, and diminished heart sound. And the prior treatment is pericardiocentesis, that is skin puncture at the junction of the epicondral junction and evacuate the present pressure. Next, followed by circulation. Shock here is because of hypovolemic, so it can be because due to blood volume. If more amount of blood volume is lost, the shock can be seen. And next is followed by the cardiac output and bleeding. The initial step is managing shock in the injured patient is recognize its present and clinical presence of inadequate tissue perfusion with the help of NIBP or any parameters. Next is rapid and accurate assessment of injured patient's hemodynamic status. Next, here elements of clinical observation include if the patient level of consciousness is altered, or skin color is gray, ashen, facial skin pale, and pale extremities are present, and pulse is rapid and thready. Second step is identify the probable cause of shock. That can be because of any trauma or because of any contusions into the of organs like that. Hemorrhage is the most common cause of shock in the injured patient. Adequate fluid volume replacement, IV fluid, the crystalline shock can be used. Next is the sources of bleeding. That is because of chest X-ray. We can done with the we can identify the bleeding in that with the help of chest X-ray. In abdomen, you can identify sonography or DPL or CT pelvis X-ray like that. In rectoperitoneum region, you can use the pelvis X-ray. Later on, CT you can identify. Next, in the long bones, you can identify in the clinically or X-ray. Femur fracture will involve up to loss of 500 ml. And in externally, we can look. Next is followed by the FAST, that is method. It is acronym for Force Focus Assessment Sonography in Trauma. Here, in there are 4 points. In there, the first point is the pericardial view, and second B point is the right upper quadrant, followed by C, left upper quadrant, and D for suprapubic view. Here, the sonography is done, and you can identify fastly where the bleeding is coming from. And the bleeding should be arrested in following methods. That is, first one is the hemostatic resuscitation, direct pressure, reduced pelvic volume, or you can say operation, hemostatic agents, embolization, or splinting of the long bones. And nasal pack can be done in the case of maxillofacial injuries, that can be because of Kesselbeck's plexus, or can be because of the any arteries present in the posterior side, or because of the little's area. Hemostatic measures include external hemorrhage, that is manual pressure over wound, and tourniquet application. Internal hemorrhage can be corrected by measures using chest decompression, application of pelvic stabilizing device or extremity splints, and definitive management. Definitive management include surgical or interventional radiologic treatment, pelvic and long bone stabilization. Next is shock. It can be that is the part can be divided into obstructive and non-obstructive. Obstructive shock can be of two types. That is tension pneumothorax and cardiac tempo. That is we have discussed earlier. And non-obstructive include disruptive. That is septal shock, anaphylaxis, neurogenic. And non-distributive include two types. That is hypovolemic. That is due to the hemorrhagic blood loss, and that's next thing to the cardiogenic shock. And this is a table showing the hemorrhage classes, that is class 1, 2, 3, 4 based on the blood loss. and with blood loss is up to 750 ml is class 1. Class 2 includes 750 to 1500. Class 3 includes 1500 to 2000, and class 4 includes greater than 2000 ml. Percent of blood loss can be 15 to 40%. Pulse rate will be increasing. Systolic will pressure will normal in class 1. Class 2 it is decreasing. Class 3 and class 4 same, followed by pulse pressure, and respiratory rate will be increasing, or urine output will be decreasing, and mental status will be confused lethargic in class 5. And initial food replacement depends on crystalloid and blood solutions. Next is the disability. Disability is a neurological evaluation. So it establishes the patient level of consciousness and pupillary size and reaction. It should identify the later rising signs, determine spinal cord injury level if present, and identification of neurological injury and prevention of further and secondary injury.